All right. Well, good afternoon, everybody. Welcome to SEVA VentRounds Express. And today we're going to talk about something that we have. I mean, we usually don't see much status asthmaticus. You usually see, I don't know, once a month, something like that in our ICU. And in the last represent the Cleveland Clinic. Here are disclosures for Rob and myself who direct this course. Right. These are recorded sessions, so if you don't want to be recorded, keep your microphone muted. We may call upon members of the audience to comment. If you want to comment, use the chat function, or you can unmute your phone if you or microphone under those circumstances. As now we always do, we start with a little bit of SEVA key knowledge, and today we put in this slide in which what we're demonstrating. This is the mode volume control in which we're controlling the flow in a square waveform. So here you see the flow being controlled as a square right here. So it's continuous, the flow, and it's controlled by the machine. And so the pressure is dependent on the resistance and the elastance. And to highlight that, so again, here you have the pressure the flow being controlled by the machine. And you can see two waveforms, one overlapped on the top of the other. So this one with the dashed lines would be what would happen in the baseline situation. And then we increase the resistance, and you can see the difference in pressure or how this raised. And to highlight that this is the resistive component, we put here that the resistance component is constant because it's a constant flow, and so if you multiply that times resistance, gives you the resistive load. And so just by increasing the resistance, the amount of pressure that contributes to the total load from the ventilator is higher. And that you can see it compared to the elastic load. But today we're talking about the resistive load, but you can see that it just increases the first step up. And then if you do an end inspiratory pause, you're going to see that pressure drop by the same magnitude as the first step up. So you see this increase and decrease. And so that's during inspiration and when we're controlling the flow. And then during expiration, what we're controlling is the pressure because we control the PEEP. And so there, what you would expect is the exponential decay. And if the resistance is increased, you will see a prolonged time constant. Rob, any comments here?
Yeah, just to point out that the equations at the bottom of that slide, that's the equation of motion. And the graphics that we see on a ventilator waveform are nothing but the graphs of the equation of motion. So pressure, and that's why we have pressure, volume, and flow in that order. And the shaded areas, the green area is what we call the elastic or the resistive load, which is resistance times flow. And the blue shaded area under the pressure curve is what we call the elastic load or elastance times volume. That's where all that stuff comes from.
That's wonderful. Thank you for highlighting that, Rob. And so here's the time constant, and I think that any person that manages a ventilator needs to be knowledgeable of the time constant. And Rob, would you want to talk to us about what the time constant is, please?
Well, first of all, the idea of a time constant comes from solving the equation of motion for example, expiratory flow. And in that equation that is the solution that shows flow as a function of time, there's this term resistance times compliance. And if you multiply resistance times compliance, the units cancel out and you get seconds. You can check that for yourself. And it turns out that it has a mathematical meaning. So for example, if we see the curve that's going up and to the right, the rising exponential, that would represent expiratory flow or inspiratory volume during pressure control. And the same thing for the expiratory flow coming down, or the expiratory, the exponential curve coming down. So the point is that a time constant is a unit of time, And after one time constant has elapsed, either during inspiration or expiration, then the exponential curve will change by 63%. So that means that during pressure control, 63% of the volume is delivered in one time constant, or for any mode of ventilation, after an expiratory time equal to one time constant, then you will exhale 63% of the tidal volume. And it continues on like that. Each time constant, is there another 63% change, so that after about 5 time constants, there's very little, for example, expiratory flow or volume left, and very little tidal volume left to be delivered during pressure control ventilation. So we say that the process is complete after 3 to 5 time constants. And the significance of that is a big deal when we're trying to interpret ventilator waveforms. For example, if you look at the expiratory flow curve, a long time constant means that it takes a long time for flow to come back to zero, and the probability of gas trapping and auto-PEEP increases. So that's it in a nutshell.
Thank you, Rob. I appreciate it.
Mhm.
And this is key not only for pressure control. So right now we're controlling volume, but we'll see some examples in which we were controlling pressure, and so you would see during inspiration, and as Rob said, we always, regardless of the mode, we would see it during expiration. The key thing, or the one of the messages that I would say for you all to recall is that, because this is a multiplication, in reality, if you think about it, if your time constant is elevated, okay, that means that either the resistance or the compliance is high. And most of the time in the ICU, the issue is not that the compliance of the lung is high, but it's actually that the resistance is high. So if you see a prolonged time constant, that usually means that the patient has a increased resistance plus minus compliance, but usually that's what it means. On the contrary, if you see the time constant to be short, it means that one of these has to be low. And we know that resistance being low has never been an issue. That actually it's a good thing. Which means that the only cause that it's pathological in the ICU is that if the time constant is low, it has to be that your compliance is low. So as you see that the time to reach baseline is prolonged, that means that the time constant is prolonged, which means that the resistance is increased. And so I thought that I would show a couple of really so just to get your brain activity going. What you have here is this is very recent, the pH of a patient, and you can see the amount of CO2, and this is a different patient, but it's in this, I mean, these are all in the same week. And you can see the size of the lungs really increased in this individual. You can see essentially every single rib space. The diaphragms are all the way to the base and pushed down with a heart that is just hanging in the middle with an ET tube in place. There's no subcutaneous emphysema, but this is what we're seeing right now. So I'm just trying to frame you in which you see hypercapnia and a enlarged lung fields. Immediately your brain activity should move towards this patient is having an obstructive process, and it could be status asthmaticus, or it could be that they have a ET tube that is kinked, or whatever you want, but this is the classic finding. So now that you're in the mood for waveforms, I'm just going to put a series of waveforms for you to be able to take a look at it. So in our classic fashion, here's the first waveform. So in the chat, or if any of the attendees wants to give it a try and unmute yourself, I mean, let me know, and then you can read the waveforms and go over what is the tag, what is the load, although the load is going to be relatively easy because I just told you what we're talking about, but regardless, and then the PV discordance that we see there, and we can talk about that. So as usual, I'll give you a minute to read the waveform, look at it with peace and love, come to terms. Okay, I'm starting to see some. And remember, you can put me everything you want, tag, load, PV discordance, all in your same item. Very good. I start seeing that the team is inputting the tag. Some comments coming in. So the majority of you have chosen for the tag for this mode VCCMBS, and just to highlight how do we know that, and this can sometimes generate some challenges. There's two ways to know what the tag is for the ventilator. One is recognizing the screen, and so this is a servo U, and seeing what the mode, and we put the mode all the way on the top, and then using either the Vent Mode app or one of our what we call Rosetta cards or mode map cards, which have all the cards and the taxonomy. And another one is just to go through the whole exercise of recognizing and learning how to identify the modes, which we teach on the course. However, what I would highlight here is normally you would expect a waveform that looks beautiful, a square waveform. So it should look essentially like that. And some of the questions would be, well, Eduardo, we know that this is volume control because we have read this, we use the taxonomy, but however, we don't see that on the waveform. Actually, the flow looks pretty, it doesn't look square. It looks, this is actually exponentially rising flow waveform. And a reason for that, just to clarify, some of the ventilators may not display what you expect to see. In this case, whenever we see this little symbol, what we know from the engineers for this ventilator is that this essentially creates a simulated waveform based on what they assume that the trachea would be seeing. And Rob, you can correct me if you hear anything, but that's what this flow. But essentially, the ventilator, if we take this out, would show you the real waveform, which is a square waveform. And we know that too because the information that we see on this waveform is similar to what we would be seeing on the pressure waveform if it was a square waveform. But you see a very so this is a volume control, and all the breaths, the two breaths that we see here are controlled by the ventilator, so they are triggered by the ventilator. And then the mode is set point because you essentially set everything. You set your I time, you set your tidal volume, you set your respiratory rate, in this case the PEEP too. So that's the tag. Rob, any comments on the tag for this mode?
No. I'm wondering, on this ventilator, you can adjust the inspiratory rise time for not only pressure but also flow. So that could also contribute to the sort of rounding of the flow waveform, but you can't tell by looking at it.
Yeah, and that's why I put this whole. Actually, that's a great point. You can see here it says T inspiratory rise all the way on the bottom of the screen, and that's what Rob is talking about. So these ventilators, you can decrease the speed with which the flow is being delivered. Don't ask me what's the benefit of this, but that they have that, and you can see that we set it at 0 so that it would be a square waveform. Then many of you identified, as expected, this beautiful resistive load. And the resistive load is present on both waveforms. You can see during inspiration, there's the rapid rise on flow. And the rapid rise on flow, in flow causes a rapid rise on pressure. In this one, we didn't put an end expiratory pause, but there's a very rapid rise on the pressure on this patient, and it's essentially because we're delivering tidal volume very fast very, very rapidly. And then during expiration, so whenever I see something that tells me that this may be resistive during expiration, I looked at expiration, and you can see that during expiration, actually during that, each one of these markers, this is 1 second. So from here to here is 1 second, 2 seconds, 3 seconds, 4 seconds, and plus this little bit. So that's 5 seconds, and the patient doesn't reach baseline, which is consistent with a very prolonged respiratory, inspiratory and expiratory resistance. Rob, comments?
Sometimes people get confused. Well, why do you have a high peak expiratory flow and then a real slow expiratory flow at the end? So why isn't that a nice, smooth exponential curve? And the reason is that that high peak flow is associated with a very small volume, right? All that is the patient circuit discharging its compressed volume. Now, patient circuits have compliances somewhere around 2 or 3 milliliters per centimeter water, and you multiply that by 30 centimeters of water, so you got almost 100 mLs that's going to get expressed out there immediately at a very high flow, and that's why you see that funny looking curve. The
Yeah, that's a
high,
great.
yeah, right.
Yeah, that's a great point, Rob. I mean, actually, you at the bedside when you're dealing with these very high distending pressure, you can see how the circuit distends at the bedside of the patient, and then it releases rapidly that volume. Very
I'd
good.
also point out that the compliance here is apparently very low, like around 30,
Yeah.
29.4. So this patient's got an elastic load as well as a resistive load, but the resistive load is predominating. And a rule of thumb is compliance of 40 is a mild ARDS. I mean, 45 is mild ARDS. 40, no, yeah, moderate is 40, and severe ARDS is about 35. So 35, 40, and 45 are the numbers you want to remember. Above 45, you're getting more towards normal compliance.
Yeah.
This is a rule of thumb.
This was a really interesting, and we can talk about the compliance, but this patient actually, you can see we're on 0 PEEP at this point and ventilating her. We did a maneuver to set the PEEP, but the auto PEEP on this patient was 10 to 12. And so the amount of air trapping, and I'll show you some waveforms at the end, was pretty important. There's, in terms of PV discordance, some of you highlighted that there was no patient effort, and that is the case. This patient was deeply sedated and paralyzed and had no patient activity. So there's no evidence of trigger. There's no work shifting. There's no cycle because it's all set by you. And some of you recognize these little perturbances on the flow that are pretty rhythmic, and you can actually, if now you start seeing them in order, you realize that these are cardiac oscillations that are occurring at a very rhythmic in a very rhythmic contraction and oscillation. And sometimes an important thing is this will become more evident as the flow is decaying, and you may be able to see them. So, and this may have to do with how much there's distension of the airway with the pressure, and how much is it transmitting or deflecting the airway with the cardiac oscillations. But you will see them here, but they're not major. They're not generating a lot of flow or abnormalities. So that's what we see here, a really active resistive load on this patient. Let me see what else is on the chat. Rob, any other comments?
No, just that those perturbations are high frequency, about 2 per second. So it's not likely
Yes.
that it's going to be someone breathing. It's just a heart rate.
Right. And there's a question here about does the waveform of expiratory flow with high resistive load like this one change based on the level of the obstruction, small airways versus large airways. Rob, any comments there?
As far as I know, you can't distinguish it.
Yeah. Yeah, it would be hard for me to figure out a difference between them, because when you do the resistance times the compliance in the time constant, you're talking about the average of all the resistances in the system, correct?
That's right. The equation of motion just assumes that you have one lumped resistance that represents all the airways, including the artificial airway.
Now, some people get, and we're going to talk a little bit more about our strategies of ventilating these patients, but we're going to show a little bit that the auto PEEP on these patients is directly related with the expiratory time. So if you increase the respiratory rate, which is a urge that many clinicians have when they see such a high elevated CO2, that will lead to more air trapping, which will lead to lower compliance and even worsening BQ matching, which was the case on this patient. All righty. Questions? Any other comments? Okay. So let's take a look at our next one. This is a different patient. Let me see. Actually, this one. So this is the same patient before or after. I don't remember if it's before or after, but now things have changed a little bit, and you can see the waveform. So again, what is the tag? What is the load? And then any PV discordance that you may see here. And I'll give you a couple of minutes to type in. See, things are starting to come in. Very good. So we start seeing the entry. So the tag for this mode, and you have it here again, we put it all the way on the top, and is pressure control. Even though it says PRVC and we set a tidal volume, that doesn't mean we're controlling volume. It's a pressure control mode. It's an IMB mode. And it's what we call type 2. And it's, sorry, adaptive. All right. Very good. So what does that mean? Is at least in this sample that if I didn't put the mode up here, you would not be able to distinguish the mode. In reality, you probably would just say this is pressure control. But now that I put the mode here, what this means is that we're controlling the pressure during the breath, even though this ventilator is not, well, any ventilator is not very good at controlling the pressure. They're better at controlling the flow, but they're controlling the pressure. And you can see that the flow actually, it's not a nice decaying. There's evidence of PMOS, as many of you recognize. It's IMB, which means intermittent mandatory ventilation. And although you don't see any spontaneous breaths, these two breaths that you have here are triggered by the machine. And we know that because there's no change in the color of the waveform, and there's no features actually on the waveform that tell me that the patient is triggering the ventilator. And then it's type 2, which means that when it detects the presence of spontaneous breaths, it will switch to volume support, which is essentially PRVC, but you don't control the eye time. And then the targeting scheme for PRVC is adaptive, meaning that we move the inspiratory pressure up and down to achieve the tidal volume. And for the spontaneous breath, which is volume support, is also adaptive. It will move up and down the pressure to achieve the tidal volume. Rob, comments?
Nope, it's all good.
So really good eye from the team recognizing that. What is the load? The load is super resistive. During inspiration, you cannot make it out because there's actually presence of PMOS. So during inspiration is PMOS. There's presence of muscle. No, otherwise, you would expect to see this to decay exponentially down, but instead of that, you see this increase on flow up here. That tells you that this patient is doing inspiratory effort. But during expiration, although at the beginning you see evidence of PMOS, and we'll talk about that at the beginning, later, you do see again that the expiratory flow continues, doesn't never actually reach the baseline, and this is consistent with a resistive load. Now, we could argue if there's evidence of activation of the expiratory muscles, and that's possible. You would have to detect that at the bedside to see if that's the case. But I mean, here there is severe flow limitation that creates this flow that essentially is at baseline. I mean, it doesn't reach baseline. There's no variety or anything. And then the next breath triggers, and then the patient follows up with an activation. So for all of you that recognize this as an early trigger, that you're correct. And we know that because there is a mandatory breath followed by evidence of PMOS. Now, there's many reasons for this pattern in the literature, many. One of them is reverse trigger, which was the case under this particular patient, in which it was with every single breath, even if we drop the rate, she would trigger a breath. So this is early trigger, and the subtype probably would be what we call reverse trigger. We don't see any evidence of normal trigger, no late, false, or failed. And during inspiration, there's an amount of work shifting, which means that the breath is getting larger because the muscles are activating on the patient. But do remember that whenever we see the first discordance or some of these discordances are gonna cause others. So in this case, for example, early trigger is causing the presence of work shifting, and it's causing the presence of what we would call early cycle. What that means is, and you see that here, it's actually very nice how the waveform moves towards the baseline. Right here, it moves towards the baseline, and that means that the patient was the early trigger, the diaphragm contractility was continued to exist, and then it relaxed, and then the exhalation occurs. So when we see that, we usually just call the first one the early trigger, because that's what's causing the rest of the abnormalities. If not, you would be kind of double counting the discordances. And then during expiration, perhaps some expiratory work, but very high resistance. All right. So I see some comments. Rob, you want to comment about the auto peep, please?
Yeah, I typed it in there, but basically, auto peep will cause failed triggering if the PMUS is less than the auto peep. So you said this lady had an auto peep of 10, but if she was only strong enough to generate a PMUS of 5 or 6 or 7 or 8, then you would see that the flow waveform tries to go towards 0, but the PMUS, if the PMUS is not as high as auto peep, the flow will never reach 0. And then it has to be even more than that to get the flow to go above 0 high enough for the sensitivity to recognize it. So yeah. Auto peep causes failed triggering.
And so in this patient in particular, what I can tell you is that when we repeated the measurements, I mean, we were attempting to wake up the patient, and so this was during a spontaneous awakening trial, and hence the mode. So we knew that there was going to be discordance, and we wanted to avoid double triggering on this patient while on volume control. So that's why we placed the patient on PRVC, and so that if the triggering would commence, that they would be able to trigger on volume support and get enough support, but would not double trigger. And that was the aim of this mode. But instead of ever activating volume support, the patient had early trigger, repeated early trigger, and that was leading to worsening on the auto PEEP and the hemodynamics. So at times the vasopressor requirements would shoot up, and I'll show you an image. Actually, this is an image of this is what things were in better shape, but you can see with every breath delivered by the ventilator how the blood pressure would start dropping after that, demonstrating the decrease on the venous return to the heart. And then as it was starting to recover and going up again, the next breath came and boom, it would go down. So there was a lot of interaction with hemodynamic interaction because of the level of auto PEEP. And this is a common question that we get asked, which is how much auto PEEP is bad. And I would answer that this is a manifestation, an hemodynamic and gas exchange manifestation. In some patients, they have a high level of auto PEEP, but they don't have hemodynamic manifestations. And there's patients like this one, which with modest amount of auto PEEP. At some point, we had her at, I think, 8 of auto PEEP. That was enough to still create major disturbances, hemodynamic disturbances. So, yeah, it's an important topic to continue to discuss. Rob, any comments?
No, it's a complicated topic.
It is.
Yeah.
And finally, we put this one. And I thought that I mean, this would be a good day to extend a little bit the rounds, but this is a patient that it's a different patient with severe end-stage COPD. And so for the sake of time, I'm just going to guide you through the waveforms. And the tag for this patient is pressure control, IMB, type 2, SS. And you can see that here this patient is completely passive. There's no evidence of PMOS, and there's evidence of resistive load during inspiration and expiration. And during inspiration, you see that the flow, even though it's set at around 1 second, the patient doesn't decay much. And if you can imagine how if we extended the inspiratory time, it would take a fair amount of time for this to reach baseline. So increased inspiratory resistance, at least by the time constant. And then during expiration, again, it is taking this patient 1, 2, 3, 4, around 5 seconds again to exhale. So really challenging, high resistive load. An interesting thing that will help you is, I mean, in this case, we placed the patient with an end-tidal CO2 monitor. And so this is really cool with some of the technology that is available, because although we always have it on the monitor on the wall, now we can actually correlate it with the waveforms at the same time. And so you can see the amount of time, the amount of dead space that this patient had, and it has the classic shark fin that never plateaus. I mean, at the end of 5 seconds, there was still flow, and it had not plateaued, which tells you that there's empty, a very prolonged time constant units still emptying their content out. And so the faster the rate, those units will not be able to empty out. They will remain increasing the dead space. So by doing this, you increase the efficiency of your breath in eliminating the end-tidal CO2. And actually, with this ventilator, we also are able to measure the volumetric CO2 and titrate a little bit better. In this case, there's no patient-ventilator interaction. This patient was passive at that time, and it was not from paralysis. It actually was from sedation. So we stopped the sedation, and again, he's on this mode because we are anticipating the patient waking up and interacting more of the ventilator. So you will see that although this patient had a rate of 15, the aim for the patient is that as the patient starts waking up, it starts activating pressure support, and we don't use anymore this baseline respiratory rate, and the patient can regulate itself. Comments, Rob?
Nope, looks good.
All righty. So the final message that I had for you is there's some interesting items that we are doing these days. What you have here is the volumetric CO2 being measured, and this is with a machine that actually is no longer produced but still available out there, which is the NICO. And the NICO, in this case, we place the PEEP here, so you have the ability to customize this screen. So you see the PEEP, you see the volumetric CO2, so the amount of CO2 exhaled per milliliter, and then the plateau pressure. And in this case, you can see, I'm just going to walk you through it, and we were titrating the PEEP according to the Karames method that was described in 2002, I think. I'll show you the graph in a second. And what you're seeing here is the PEEP was set at 0, and then we started raising the PEEP up to according to the amount of auto PEEP that the patient had. And then down here, we were measuring the plateau pressure as we were increasing the PEEP. And then just for kicks, although this was not described on the paper, we put the volumetric CO2 to see at which point of the PEEP did the volumetric CO2 elimination was the best. And so if I'm going to just fill this waveform with my cursor so that it looks better for you. So you can see, so that's the plateau pressure, and you can see as we increase the PEEP, the plateau pressure did not change until a certain point in which it started increasing. And the VCO2, when we went to 0, went down, and then as we started increasing the PEEP, it went up to a peak amount. And then as the PEEP continued to increase, and actually we started over distending, the VCO2 went down. And I know that this is a tiny screen, but it's pretty cool to see. And so if you look at the Karame paper in 2005, and I really like this paper because it helps us do this. Yes, Ariel, I did an inspiratory pause on all of them. And so these are the graphs that they showed with the 3 behaviors that the patients with obstructive lung disease had. And so there's 3 different behaviors. I'm going to call them A, B, and C. And so this is what we did for this patient. This is the plateau pressure over here. Sorry, the plateau pressure is these little triangles. And as we increase the PEEP from 0, this is the percent of the external PEEP. So in this patient was 12 or 10. That would be 100% of the external PEEP that we are applying. And you can see as we started going up on the PEEP, the plateau pressure remained stable, and then suddenly it started going up, which is consistent with that we started to distend the patient. In this patient B, from the moment that we started going up on the PEEP, or they started going on the PEEP, you start seeing your plateau pressure start to climb, and then suddenly it really raises up. So consistent with that, these patients are already over distended, and you're over distended even furthermore. So over here, I think that there's probably some area of lung that you can recruit and improves volume, or you open certain airways and it maintains the volumes the same. But on C is what all of us would love to see, which is you start giving PEEP, and then the PEEP stents or opens up the airways, and then the overinflation goes away, and you can see the lung volume goes down and the plateau pressure goes down. That would be like yay, everybody happy and super smiley. what we saw is this one, and so we ended up setting up the PEEP around this number. It was around 8 for this patient, at which the patient would obtain the maximum CO2 elimination efficiency, and the plateau remained the same for her. So that's all I have for you folks today. Comments, Rob?
Nope, just in terms of the time constant, if you splint the airways open, you decrease the time constant because you decrease the resistance. And if you can't do that, it doesn't work.
Any other comments? All right, Ariel, who scored the goal?
USA.
All right, good. Excellent. Well, thank you everybody for your time and energy connecting and bypassing the game. I hope that you can watch it in a little bit. Have a great day. Thank you.